I'm going to introduce our two panelists for the debate on GnRH Agonist for ovarian protection. Presenting the pros will be Matteo Lambertini. He's an associate professor and consultant in medical oncology at the University of Genova in Italy. He is mainly focused on the care of breast cancer patients and is deeply involved in breast cancer research. Above all, he has a particular expertise in the management of breast cancer in young women with specific attention to fertility and pregnancy-related issues that they must face after diagnosis. During his medical oncology training, he had the opportunity to work and collaborate with several national and international leading experts in the field, and these experiences have played a crucial role to deepen his skills in the management of breast cancer in young women. Thanks to the support of the European Society for Medical Oncology, in 2018, he completed his PhD at the University of Brussels in Belgium with a project entitled Unmet Fertility and Pregnancy-Related Issues in Young Breast Cancer Patients. He has authored more than 250 publications in peer-reviewed journals and book chapters. He's an active ESMO member since October 2011. It's my pleasure to welcome Dr. Matteo Lambertini. And before I let him present his part, I'd also like to introduce our doctor presenting the cons today, Dr. Rodriguez-Wallberg. She is a professor of reproductive oncology at the Karolinska Institute in Stockholm, Sweden. She is a consultant in the Department of Reproductive Medicine and the head of the clinical program of fertility preservation there. A reproductive medicine specialist by training, her research focuses on how cancer patients impact young patients, the reproductive health, and on the safety and efficacy of procedures for fertility preservation. She also has published extensively in reproductive medicine topics, including assisted reproductive technologies, fertility preservation in adults, adolescents, and children, obstetrical outcomes, and specific risks in patients with cancer or benign conditions, transgender reproductive issues, reproductive endocrinology, genetics, and menopause. Her research encompasses clinical, epidemiological, and translational research, and she's the head of the Laboratory of Translational Fertility Preservation at Karolinska, I'm going to have you pronounce that, Kenny, Institute. For the past 20 years, much of her work has focused on fertility preservation. She has published in more than 150 peer-reviewed papers. Please welcome Dr. Kenny Rodriguez-Wallberg.
Good afternoon, everybody. It's really a great pleasure and honor for me to be standing here among giants in the field of fertility preservation. So I've read a lot of your papers, so it's very nice to meet you finally in person. And a big thank you also to Dr. Salama for all the work that he's doing in the Oncofertility Consortium. So my task is to address the so the positive side on the use of GnRH agonists for ovarian protection. These are my conflict of interest. Actually, most of them related to my work as a medical oncologist. For today's talk, the main one is that I'm a medical oncologist talking about GnRH agonists during chemotherapy to fertility specialists. So please be nice to me. Here the outline. I'm going to try to highlight in the introduction that what we discuss is not fertility preservation, but it's protecting ovarian function, so the endocrine function of the ovaries. And then I will go into the biological rationale, preclinical evidence, as mostly the clinical evidence that makes now this procedure as a standard of care, at least in the breast cancer field. As an introduction slide, I will start with the most important for us as medical oncologists, which is the first step of the oncofertility counseling, what we have to do before referring the patient to you, which is discussing the risk of gonotoxicity that we know quite well with chemotherapy. The type of chemotherapy, number of cycles, the age of the patient are the critical factors in this type of counseling. This is improving. It's still not optimal. Not all of us discuss this issue, but I think it's improving over the years. And what we know quite well in the oncology field is that risk of gonotoxicity translates into infertility, and a lot of our patients, young women, newly diagnosed with cancer, are interested to have a potential pregnancy in the future. So fertility preservation is very important for at least half of our newly diagnosed patients with cancer. There is a lot of literature saying that around half of young women with new diagnosis of cancer will be interested to potentially preserve fertility. However, premature ovarian insufficiency is not just infertility, but it's also early menopause with all the side effects of early menopause. Anxiety, depression, sexual dysfunction, and so on, that are major side effects that can have a very important impact on the quality of life of our patient for the rest of their lives. And if we think about patients that are very young, even below the age of 30 years, we really don't want to have them entering menopause at such a young age. So this is to stress the fact that it's important fertility preservation, but also the more general concept of ovarian function preservation is of relevance for our patient. This is a study, a prospective study that is ongoing in my country called PREFER, in which we want to address the needs of our patient in terms of fertility and ovarian function preservation strategies. So here is the data from our center. If we counsel 100% of patients with breast cancer regarding the risk of gonotoxicity, and if you look at the blue bars, who are patients below the age of 40 years, so those that we refer to fertility preservation strategies, we see that around 20%, so 1 out of 5, will be interested and accept a cryopreservation option, so is interested in a fertility preservation procedure. But a lot of them, more than 90%, are interested in ovarian function preservation, which is protecting the ovarian function and avoiding the side effects of early menopause. And for us as oncologists, it's very important to address this issue of early menopause, because not only fertility preservation, but also the risk of developing early menopause, because we have a lot of studies showing that if we do not properly address this concern, we may have patients that are less adherent to treatment. They may decide to avoid some of the chemotherapy agents that we propose to them. And so what we say is that discussing these survivorship issues is key also from a survival standpoint, because receiving a suboptimal treatment can translate into worse outcome for our patients. So again, fertility preservation, but also avoiding early menopause is of relevance. I'm pretty sure that Kenny will focus on the biological rationale for this strategy. That I can say that, yes, this is still a debated issue. It's still not fully clarified. We have a hypothesis that it can be an indirect protective effect, so stopping FSH production, putting the ovaries in a sort of dormant state during chemotherapy, so that they are less sensitive to the gonadotoxic effect of chemotherapy. But we may have also a direct effect, an anti-apoptotic effect in the ovaries. But indeed, this is still controversial. Preclinical evidence looking into the mechanism of action, there has been a lot of studies over the past years. Most of them have shown that this strategy is protective, but not all of them. Some did not show any protective effect for GnRH agonist. But what I wanted to highlight with these slides is that most of these experiments have been conducted in mouse and rat models, which may be not probably the optimal model to study this technique. We definitely need more human models. This is just an example from our group, in which we have found a potential anti-apoptotic effect directly on cumulus cells in the ovaries. But definitely we need more human models to study this subject. In terms of clinical evidence, indeed, this has been a debated topic for many years, and we have exchanged a few letters with Kenny a few years ago before becoming very good friends. However, I will say that now this topic should not be debated anymore, should not be considered as it is this afternoon in the experimental strategies, because the data we have, particularly in breast cancer, the clinical data, I think are quite clear. This is a meta-analysis based on abstracted data from 12 randomized trials that randomized premenopausal women with breast cancer to receive chemotherapy alone or chemotherapy plus concurrent GnRH agonist during chemotherapy. If we pull these studies all together, we'll see that the use of GnRH agonists during chemotherapy will decrease by around 64% the risk of developing premature ovarian insufficiency. The primary endpoint of these trials was not fertility outcomes, number of babies, but was rate of premature ovarian insufficiency. And this was defined as amenorrhea in post-treatment in most of the studies. We have some data from these trials that it may also increase the pregnancy rate. This is statistically significant, but the numbers are very small. So again, I'm not discussing fertility preservation potential, but only ovarian function potential. I think the highest evidence that we have in the breast field is an individual patient data meta-analysis of the 5 major randomized trials that were conducted in this field. We have pulled together all this data from 4 different countries, 5 trials, almost 800 patients, more than 800 patients randomized to chemotherapy or chemotherapy plus concurrent GnRH agonist. As you can see in the for the age limit, 40 years was not the cutoff to be included in this trial, but in some of the studies there was not even an age cutoff, so all premenopausal women were allowed to be included, because the primary aim, the primary endpoint was premature ovarian insufficiency rate, not number of kids after treatment. Here the data in terms of premature ovarian insufficiency, a reduction of around 15% in the rate of premature ovarian insufficiency, more than 60% reduced risk of developing this toxicity, and this benefit is observed no matter the age of the patient, the type of chemotherapy, and the number of cycles of chemotherapy. Again, some insights on a potential fertility preservation potential. This is significant in favor of the use of GnRH agonist, but still, again, I don't want to push towards a fertility preservation potential of the strategy. As oncologists, for many years, we have been concerned that giving hormones during chemotherapy may reduce the efficacy of chemotherapy, so we cannot give tamoxifen concurrently with chemotherapy because it reduces the efficacy of chemotherapy. We have preclinical and clinical data to support that. However, we don't have this concern for GnRH agonists. This is, again, the individual patient data showing same survival outcomes in patients receiving chemotherapy alone or chemotherapy plus concurrent GnRH agonist. And more recently, trials focused on women with hormone receptor-positive breast cancer, again, showing the same conclusion: there is no detrimental outcomes for those patients receiving GnRH agonists during chemotherapy. So this is a safe procedure irrespective of the biology of the tumor. One of the main concerns is that these trials have looked into the premature ovarian insufficiency as amenorrhea post-treatment in most of the cases, which it's not the best marker of treatment-induced gonotoxicity. However, now we start to see some prospective data showing a potential protective effect of this option on the ovarian reserve of our patient. If we use GnRH agonist, there is during chemotherapy, there is a higher chances of recovery of the follicles after treatment, and also AMH levels will tend to rise again following treatment completion. And a randomized trials just published end of last year from our colleagues in China has used, and this is the only trial, randomized trial that has used as primary endpoint the definition of premature ovarian insufficiency using AMH as the primary endpoint. And also this trial is positive, showing a protective effect of GnRH agonist during chemotherapy for this patient. I'm sure that Kenny will stress the data in women with hematological malignancies, where we have 4 randomized trials, all of them being negative, showing no protective effect of GnRH agonist use during chemotherapy. However, as you can see, the number of patients randomized is very low, with the largest trial conducted by Isabel de Mister, with less than 100 patients, meaning less than 50 patients per study arm. So why do we have so different results in the 2 patient population? My interpretation is that on one side is a more methodological reason. In the breast cancer field, we have more than 10 randomized trials, more than 1,000 patients randomized, so a much powerful cohort to show a difference there. In patients with hematological malignancies, more limited data with the largest trials that included less than 100 patients. But to me, probably is even more important the potential clinical explanation. So in breast cancer, we have women usually around the age of 40 years receiving treatment with an intermediate risk of gonotoxicity. On the other side, women with hematological malignancies are usually very, very young, and they can receive 2 completely different gonotoxic treatments. On one side, ABVD, which is very, very low gonotoxic, has a very, very low gonotoxic potential. On the other side, treatment with a very high gonotoxic potential, like treatment that conditioning treatment before transplantation. So if we look at the effect of GnRH agonist during chemotherapy, which is there but can be considered a modest effect, this modest effect can be seen when there is an intermediate risk of gonotoxicity. We cannot see this modest effect if the risk is too high or too low. In terms of guidelines, this is the Italian Association of Medical Oncology recommending this procedure since 2017, and since then it is reimbursed by the public health system. So all women of reproductive age receiving chemotherapy when they are still premenopausal, they can receive for free this treatment during chemotherapy. Also, the ASCO expert has been convinced finally that this treatment can be considered in the hope of reducing the likelihood of chemotherapy-induced ovarian insufficiency, but not as a fertility preservation strategy. And for the ESMO guidelines, the European guidelines, we have tried to put into a graphical aspect the concept of fertility preservation and ovarian function preservation. So what we say is that those women interested in fertility preservation, so increasing the chances of a post-treatment pregnancies, cryopreservation options are the standard of care, and then maybe after cryopreservation option, GnRH agonists can be offered. On the other side, we have, as I've shown from the Italian trial, we can have patients that are not interested in fertility preservation, but they are concerned about developing menopause at an early age. And in these cases, definitely, GnRH agonists during chemotherapy can be considered a standard procedure. My final slide, not really of the debate, but I think it's a nice opportunity to discuss this subject. If we combine the two options, so for those patients that receive fertility preservation, and particularly oocyte embryo cryopreservation, before coming back to our clinic and receiving chemotherapy, if we start a GnRH agonist, a long-acting GnRH agonist after a stimulation protocol, there's a risk of hyperstimulation syndrome. And I have a lot of colleagues in our field that have experienced that, and we have also a couple of cases a few years ago. And this is a toxicity that we definitely need to avoid, because this will lead to a delay in the start of anti-cancer therapy. So what we are doing at our center as part of a research protocol, so it's not a standard of care at all, but it's a part still of a research protocol. Our fertility specialists are triggering at the end of the stimulation protocol patient with, instead of using a short-acting GnRH agonist, they are using a long-acting GnRH agonist. Apparently, in terms of efficacy, this is probably similar to the short-acting GnRH agonist, and this will avoid the medical oncologist giving the long-acting GnRH agonist before starting chemotherapy, reducing the risk of hyperstimulation syndromes. The numbers are still small to draw a solid conclusion, but it is something that we should probably consider to develop further to avoid this toxicity. So my conclusion is that I hope that I've convinced you that there is not only fertility preservation for our premenopausal women with, that are candidates to receive chemotherapy, and ovarian function preservation can be important irrespective or beyond interest in fertility preservation strategies. GnRH agonists during chemotherapy can be considered standard of care for ovarian function preservation, particularly in the breast cancer field, where we have many randomized trials showing definitely a benefit in these cases. And none of us, including myself, that I'm a bit biased on the positive side of using this technique, we should not consider this as an alternative to cryopreservation procedure, because it's not per se a fertility preservation option. And with that, thank you very much again for having me here.
Thank you very much, Matteo. I hope this is the final, right? Because I have uploaded 3 different versions of my presentation. I'm very thankful for being here, invited to speak to you about a subject that is important for me and for my research team. But seeing you here, I am happy to see that this is important for some other people too. Let's see, how do I do this? Yeah. Well, I have nothing to discuss. And I will start by talking about fertility preservation. This is such a huge scientific progress in fertility preservation. What we see here is in blue bars the number of articles on fertility preservation per year on the PubMed, and in pink you see the number of articles that discuss fertility preservation and children per year. So this is just increasing. And over the years, we have also been able to develop methods to help our patients in very different situations. So you see the years when we started with sperm cryopreservation or embryo cryopreservation or the other methods. But if we consider ovarian protection by GnRH agonists, it's a very old story, started already in the 80s. And I will tell you a little bit how it started. It started with this paper that was published in Blood in 1981 by Chapman and Sutcliffe. And they were caring of women with Hodgkin disease, and they did biopsies on the ovaries of women with Hodgkin disease, and they could show that if the women had undergone the Hodgkin chemotherapy treatment, they had very few follicles in the ovaries after that treatment. And they were thinking if we could do something to avoid this, and they proposed that if we inhibit the stimulation to the ovary by the gonadotropins, it could be probably be protective for the ovary. And it can be done by several ways, but one way, for example, is by giving oral contraceptives to the patients. So they did that, and they presented the results of 3 women. That's the last cases in the table, where it says post-treatment, case 1, 2, and 5. And these women received contraceptive pills during the chemotherapy treatment, and when they did the biopsy after the treatment, they found that they had more follicles in the ovarian biopsy they took in comparison with women that received chemotherapy only, and these numbers after treatment with oral contraceptives were not different from the previous biopsy before treatment. So you can imagine the quality of this paper in our contemporary scientific status. But this paper made a big impact, and many people started thinking about this, and many people have started to give GnRH Agonist to protect the ovaries under chemotherapy. My first question is, will it be suitable to offer an ovarian protective treatment if we are giving chemotherapy and we want to kill cancer cells? And the answer is probably yes, if it is safe. How can we give a safe treatment? It is only possible if this protective treatment is very specific to the ovary, because if it is not, we could protect also other cells or also cancer cells. So this is not really what we should do. So it has to be ovarian specific, and it has to be effective, because this is what we are looking for. And we know about the impact of chemotherapy on fertility that is associated with specific drugs, mainly the alkylating agents, and one of the best known cancer treatments and the impact in infertility is that one from breast cancer. And we also know that the reserve of eggs is in the primordial follicle pool. This is well known, right? The other follicles that are already on development, we should not care very much about them because they are on their way to die. Only one can survive and maybe ovulate, but all the others, they are going to die, and it happens every month, so we cannot do very much about it. But if we could protect the primordial follicle pool, we really could prevent that women will develop infertility after cancer treatment. But it happens also that women are not equal, and they behave differently, also biologically, and there is this, what is probably the pharmacokinetics that varies between individuals. There is this inter-individual variation, and probably a lot of that has to do with pharmacogenetics, how the different genetics affect how we metabolize drugs, but also it has to do with age, and probably also it has to do with how many eggs we had at the beginning in this specific ovary that can make a difference between the women. And this is just to show you that the first phases of development from the primordial follicles, they are gonadotropin independent. And this is also well known. These follicles do not have receptors for FSH, LRH, and not for GnRH either. So there is a lot of written about this, and if the GnRH is protective, we don't know why. What is the mechanism? And some people have looked upon experimental data, and Matteo presented also the experimental data mainly on mice, rat, and also primates, and the studies are inconclusive from animal experiments. It seems that the original mechanism proposed, which is that there is not going to be, or we can block the FSH, LH stimulation to the ovary, is the protective mechanism. Doesn't seem to be valid. And as a researcher in fertility and fertility preservation, I wonder if you would like to have a perfect study design so we can test this in humans. And if the relevant outcome for a woman is to have a childbirth, you can imagine how difficult it is to make such a study just to go and count for these childbirths. As it is so difficult, so maybe we could go to find some other surrogate primary endpoints. And over many years and in many studies, the primary endpoints have focused on the resumption of menstrual cycles for many women. But if we will go for markers of ovarian reserve, which we have developed, and we have golden standards for markers of ovarian reserve, so maybe this is what we should measure in a clinical study to see if there is this benefit. And if we want to design the perfect study, we should go for the best experimental model, so a randomized placebo-controlled and double-blind study with sufficient time to measure the reproductive outcome, or if the hard outcome is going to be childbirth, so maybe we have to wait a lot of years to get it, but we also can use the estimation of the ovarian reserve by a gold standard. And just to give you an idea how difficult it is to design a study for this, to test if the GnRH is protective, how many patients do we need to have in each group? So there is just a proposal, 200, 300, 500 by group. Well, there are some people that have already done some calculations, power calculations, but these are done in studies when every single individual is attempting pregnancy by a treatment, for example, and then we can measure exactly if the intervention is effective or not, because all the women attempt pregnancy, and at the end we get all the pregnancies or childbirths. And by doing this, in the references 2 and 3 of my slide, then you will see that the number of individuals we need in such study, and if every single individual is attempting pregnancy and these results or not in childbirth, is over 1,000 individuals, 1,300, for example. And many of you know these papers because these are the papers that show after randomization in a good study design that there was inefficacy of an intervention where people believe a lot on it many years early from other research that was not as systematic as this one. So probably we won't make it just to see if GnRH agonist in a clinical study can be studied to see if the women deliver more children. Some people have done some good studies, and this is a randomized study that was published in 2015 that made a huge impact, also because it was published in the New England Medical Journal. So this is a good paper. And I'm just showing this as an example. This study found a protective effect of GnRH agonists in women with breast cancer. So this is a very good group where they randomize women with breast cancer to chemo plus GnRH or only chemo. And the study was originally powered for over 400 patients at the end of year 2, and it was designed for the primary endpoint rate of ovarian failure. And it will be defined of the absence of menstruation during 6 months and FSH and inhibin levels. This is what is written in the paper. However, these data are not presented in the paper. Other data are presented in the paper. At the end, they have only 69 and 66 women with complete data. But in the results, they present what is called the treatment proposal analysis. So they had 113 patients with chemotherapy alone and 105 with chemotherapy plus goserelin, what was the GnRH they used. And in the study, they could show in the line 2 and 3 that there was a significant difference in pregnancies and childbirths between the groups. The women that received GnRH had more pregnancies, and they also had more children. But in the very first line, it is shown, and I think really these researchers were very smart, they asked the women if they were attempting pregnancy. Because if you don't attempt pregnancy, maybe you don't get a pregnancy. I'm an expert in fertility. So they asked the patients this question, and they presented in the very first line. And if you calculate from the number of women that were attempting pregnancy and achieve a pregnancy and a live birth, there is no any statistical difference between the groups. So when we saw the paper published together with some collaborators, so we decided to write a letter to discuss this, and it was hard to get the letter in, but at the end they published our letter. It's very difficult when such paper is already published because so many people really believe in this. And I just want to tell you that I don't know. I want to know. I don't know if the GnRH works or not, but this study design doesn't help because also, even if it was a randomized study, all women that received the GnRH, they knew they received it. And all the women that didn't get their GnRH, they knew they didn't receive it. So the women that attempted more pregnancies, they knew that they have received an injection that could prevent infertility or protect their fertility. So they were, we don't know if they could be biased by that. But the problem is that every single randomized study up to date has been done in the same way. There is another study that I want to highlight here, and this is the study from Isabelle Demestier in women with lymphoma. And I want to present this study here because in the American study I just presented on breast cancer, the follow-up was at 2 years. But in this study from Belgium, the follow-up is at 7 years. So this is the study that has the longest follow-up of all the studies. And this was also a randomized study with long follow-up. In this study, there was no any beneficial effect in markers of ovarian reserve and not in pregnancy either. And there are meta-analyses there, and you have seen some from Dr. Lambertini here. But I will show just one meta-analysis that I think is important because this is the only one that have considered only studies that have presented data on AMH before and after cancer treatment in the patients that were randomized to GnRH plus chemo or only chemo. And this study doesn't show any effect in markers of ovarian reserve from the studies that had this data, and I think it was about 8 studies that had that data. So we have written a little bit, trying to argue how a good study should be done, but to do a study is expensive, and if you cannot convince the people that this is necessary, so it's also very, very, very difficult. But I want just to show you this sentence here from Bertrand Russell. And I think it's why I'm here today talking to you. If a man is offered a fact which goes against his instincts, he will scrutinize it closely, and unless the evidence is overwhelming, he will refuse to believe it. If, on the other hand, he is offered something which affords a reason for acting in accordance to his instincts, he will accept it even on the slightest evidence. The origin of myth is explained in this way. So my conclusion is that we don't know if the GnRH works, and we need to know. So we decided finally in Sweden to do a study. And we have designed a study that is powered for women with breast cancer because this is the largest patient group. And we know exactly how many women do we need with breast cancer that will be randomized to GnRH or GnRH plus to chemotherapy alone or chemotherapy with GnRH. And as we realize, we cannot measure pregnancies or live births because if the women do not have a partner, if the women cannot achieve pregnancy, if they have to wait after 5 years of tamoxifen or so. So there are so many other things that are going to give us some trouble. So the best will be to measure the markers of ovarian reserve that we have learned how to use in research also. And this is our clinical protocol that was actually published in the British Medical Journal online a few days ago. So now everyone can read the protocol. And I'm very happy because yesterday at your very beautiful ceremony, I discovered that we are not alone. Jennifer Levine and the Children's Oncology Group are also planning to conduct a similar study. They presented this idea yesterday, and I was immediately looking for her, and I said to Jennifer, I love you. This is what we need. We need these studies. And of course, Jennifer Levine and the Children's Oncology Group can do this here with your help for children, because maybe you don't know this, but even out there, girls and adolescents are receiving this GnRH injection when they have lupus or when they have rheumatic diseases, and they receive just a little bit of alkylating drugs for vasculitis or so. This is so spread everywhere, and we don't know if this is giving any benefit or not. And we don't know either if it has any potential secondary effects. So our study in Sweden is unique because this is the first study that is double-blind and placebo-controlled, and everyone that will contact the patients will be blinded, and only the people that randomize and give the injection will be unblinded. The patients will be blinded, and we will give the intramuscular injections on the back so they don't see the injection. And this is the first study that also will include both adult women and teenage girls. And this is the first study powered for changes in markers of ovarian reserve. And we need 300 women with breast cancer. This is the power we have calculated to randomize. But for the girls and women with other diseases, we will get the data, but we don't have the power for these groups. Is there more data out there? Well, there is a paper that was published in 2009 that has been recently retracted August this year. In this study, it was a randomized study of GnRH during chemo or only GnRH for breast cancer. 40 women in each arm, one woman dropped out from each group. A bit too perfect, I thought when I read the paper in 2009, but this study has now been retracted formally because there are issues with the data. And I'm also doing some other things. Sometimes I do research in epidemiology, and in Sweden we have the population-based registers. And I have been thinking very much about this question, how we can know if this GnRH is beneficial or not. So I decided to go and interrogate my registries. I wrote an ethical permission, and I got the permission to use the data. I could identify all the women and girls in Sweden that have received a cancer diagnosis. And I could identify, using the prescription drug register, all the women that received GnRH in connection with their cancer diagnosis at the time they started chemotherapy. And we found over 20,000 women and girls. This is adolescent and adult women with many diseases, but largest groups are breast cancer and lymphoma. And then, using the registries, we can follow all these patients. We can see if they did fertility treatments, IVF. We can also see if they had delivered a child or not. And interrogating the registries, we found out, following these over 20,000 women and girls, that the group of women that actually received the GnRH agonist in connection with the chemotherapy, they haven't got more children than the women that didn't receive this injection. We have this paper on review, but I think soon maybe it could be out. There is a debate that we published in Fertility and Sterility some years ago, and I think Matteo and I participated in this, and we are still friends, so that's very good. But when I started to discuss my study design with the oncologists and pediatrician oncologists in Sweden, the people that haven't started to use routinely the GnRH, they were interested, and it's mainly because the Hodgkin disease has not shown the same results in these studies or meta-analysis as breast cancer, and the data on breast cancer has been more convincing. So for breast cancer, the doctors told me, I'm sorry, Kenny, I am a believer. So we cannot be in the study because we already believe. And I hope that some of you maybe will feel that this study is needed, so maybe we can contribute to recruit the 300 patients with breast cancer that we need. We plan to do this multicentric. We have already started in Sweden, but there is interest in other countries to help us. And that was my last slide. Thank you.
Any questions? I guess while we're waiting, Dr. Rodriguez-Wallberg, I guess my question for you is, I understand that you don't necessarily think we're going to find an effect, but in the meantime, what should we be doing? Like, what if it does work?
Well, if it works, then we can stop freezing eggs and ovarian tissues. We can just give the GnRH if it works. So it will be great if it works. But if it doesn't work, so we can stop doing something that does nothing.
Yeah. So in the meantime, are you giving it? I guess that was my question.
No, in the meantime, we need to do the study.
Maybe if you can just make a comment on this aspect. Going back to my point of fertility preservation and ovarian function preservation, I fully agree on the fertility part. We should not push for it because there is a lot of colleagues that, from the medical oncology side, that they are offering this procedure. And because they are offering this procedure, they do not refer to fertility specialists, which is a wrong message. And I agree with Kenny, despite I'm a strong believer, I agree with Kenny that the data are not enough to support that. But for the ovarian function preservation part, I think that I will find it a bit unethical in breast cancer to enroll a patient because we use it, and didn't go into these details, but we use it also as an anti-cancer agent during chemotherapy in order also to optimize the adjuvant endocrine therapy following chemotherapy. So as a breast oncology, I'm not sure I will discuss with the patient not giving something that is recommended by guidelines and as shown in several trials to protect ovarian function. Again, not fertility, and I fully agree with Kenny on that.
Go ahead.
Hi, I'm Karen Glass from Toronto, and it was great to hear you guys debating something that I thought I knew the answer to, so maybe now I don't know the answer to. But I have a comment about one very niche thing that Dr. Lambertini brought up, which is so important. I was very, very distraught when my very good friend, the medical oncologist, gave a full dose of GnRH agonist to my patient a couple days after the retriever and put her into fulminant OHSS. And I was like, oh, you re-triggered her. Thank you very much. And so from that point on, I send out very strict emails to all my oncologists telling them you are not to start the GnRH agonist until her hormones have calmed down, probably about a week after the retrieval, because it's like triggering them again. But I was very curious to hear about you guys using, or your REI team using, the long-acting as a trigger, wondering what dose they're using and if they have data to show that it's fine for the retrieval and that the retrievals go well and their eggs mature and everything. Yeah.
Yeah, thank you very much for the question. So we use the 3.75 milligram dose, which is the one that we use during chemotherapy as a monthly injection. The data I've shown, published in ESMO Open a few weeks ago, is the first series with around 20 patients with this technique as compared to the daily dose that you use in terms of triggering. On your point, when I speak about this subject to medical oncologists, I pay a lot of attention on the point that they need to call the fertility specialist before giving the long-acting GnRH agonist, because based on this, on the hormonal levels during stimulation and so on, you can sort of predict the risk of hyperstimulation syndrome. So I will definitely not do the shot without calling the fertility specialist before.
And the timing of the trigger shot of the long-acting is exactly the same, the 35 hours that we use when we trigger?
Yes, yes, it is.
And as far as you can tell with your small series, the maturity and everything is fine?
Yeah, based on, it's still very limited data, so I don't want to push it as a potential standard option, which is not at all, because it's just a small series, but this is something that our fertility specialists are now doing for all patients with breast cancer right now. And apparently with these small numbers, it's the same, the performance of the stimulation.
Yeah, it's very cool. It kills two birds with one stone, as we say, right?
Well, it makes our lives also much easier, because we know that we don't have to do anything until 28 days after the end of the stimulation.
As a pediatric oncologist, I've been reluctant to give GnRH agonists because I was told once, and maybe you can clarify for that that it makes people feel very poorly and pushes them into menopausal symptoms when they're undergoing other very toxic chemotherapy regimens. Could you comment on that?
From my side, I don't have experience in prepubertal patient, and the evidence, to my knowledge, is very limited, so I will be a bit cautious there, and I fully agree that we will need a trial. In terms of side effect in the breast cancer trials, what you see is that there is a higher chances of menopausal-related effect in women that receive GnRH agonists during chemotherapy. However, in most of these cases, even women receiving chemotherapy alone, they will develop chemotherapy-induced amenorrhea. So in terms of side effects during treatment is a bit higher, hot flashes and menopause-related symptoms, but then in the long term you protect the ovarian function, so the goal is to avoid these side effects for the rest of their lives. In the short term, it's true, there is higher chances of side effect, but in the long term you want to avoid these side effects, which is the main goal of the strategy, it's not fertility preservation, it's avoiding the side effects of early menopause.
So I think that, like this, as with many other things, I think part of this is one size doesn't necessarily fit all. And what I wanted to mention, because we haven't gotten around to publishing this yet, and we studied AMH in a group of Hodgkin lymphoma adolescents and looked at AMH compared to controls at diagnosis across adolescents, like up to 24. And at every single age, Hodgkin's patients had significant lower AMH than the controls. And I think it sort of makes sense to us because Hodgkin's is a much more inflammatory disease compared to almost every other cancer. And so that also makes me think that like trying these mechanisms in a Hodgkin lymphoma population compared to some other populations mechanistically might be very different. And again, I think this issue of age comes up. So I'm also wondering sort of in this, like the pro-con view, whether there's a feeling that like maybe the issue is that it's good for some patients and not right for others, and how in this trying to get to how do we get there?
Yeah, it is possible. It's so much we don't know, but the rationale that it will work in breast cancer and not in other diseases when the chemotherapies can be similar, so it's a contradiction. But we don't know if we don't study the different groups individually.
Yeah, I agree that clinically, as I've briefly mentioned, there are differences between breast cancer and patients with hematological malignancies. When I discussed with hematologists at our center, I mentioned that we don't have evidence to support its use, but they normally do it also for other reasons, including avoiding bleeding during chemotherapy that in some cases can be important. However, particularly for Hodgkin lymphoma and the ABVD regimen, I'm not sure it's needed because the regimen has a very low gonotoxic potential, so this modest effect, you cannot really see it.
I think we'll have to close it.
I'm going to take the Bertrand Russell point of view, you know, no matter how you try to convince me GnRH agonists make a difference, I'm not going to believe it. But the reason that I'm saying that is, and I love your answer on that, is that that slide of the Oktay et al. Diagram isn't correct because we know there's about 4.5 months after primordial follicle recruitment before the oocytes are at all sensitive to gonadotropin. So how is it conceivable that blocking gonadotropin could have any impact on the primordial follicles, which are the only follicles you really care about with gonadotoxic treatment? So it's just, that's why I can't believe it, no matter what data you come up with. But maybe you can answer me.
No, I have. It's also difficult to believe, but there are studies also in males, in randomized studies with GnRH agonists during chemo or not, and these studies do not show any benefit in males, clearly.
Well, I understand that. I'm teasing a bit. But it just seems that based on our scientific knowledge of how the ovary works, it's just inconceivable that an agonist to block the effects of gonadotropin would affect primordial follicles.
Yeah, so that's why the defenders of the GnRH theory, they say that it's because it could be through a mechanism that is not yet discovered.
Yeah, right, exactly.
Yeah.
All right, I'm going to have to close it to any further questions so that we can move on to our next speaker, but I'm glad that this brought up so many thoughts and feelings that people can talk about at the break with our speakers. Yeah, thank you.